Hi, I'm Jerry Tan. I'm from Windsor, Ontario in Canada. It's my pleasure to present at Asia Derma 2021. And the topic I'm presenting is entitled New Acne Treatments 2021. And I'd like to give you an update on what has transpired over the past few years, including some of the new developments in the way we think about acne, the way we're looking at adding new treatments for acne, as well as what we can do with current treatments. I do have a number of conflict declarations as I have been an advisor, consultant, have been a developer, investigator, and or speaker for a number of companies involved with acne care products. And I have also developed a patient decision aid to help in shared decision-making with our acne patients at inform-decisions.org. That project was funded by the University of Colorado. So thank you for that. The agenda is the following. I'm going to evaluate and review with you the new paradigm in pathophysiology, our understanding of how acne develops from the different pathways, both innate as well as extrinsic, new treatments that have developed. And here I'm going to try to curate for you some of the treatments that I think have particularly interesting features that either we never had before or their application to other aspects where we didn't evaluate before. I'd also look at new ways of using current treatments that we have to help our acne patients, and then new ways to engage in informed shared decision-making with our acne patients so they are better informed and better able to participate in their medical care. The learning objectives are the following. What is the role of sebum in acne? What is the mechanism of action of topical clascoterone? How is sarecycline different in structure from the other tetracyclines? And as a proxy question, how much greater is the success rate when we use a treatment topically for 24 weeks compared to 12 weeks? And although the focus was on the adapalene 0.3, benzoyl peroxide 2.5% fixed dose combination in that study, it may well apply beyond it, because as you know, most of our randomized control trials for regulatory purposes end at 12 weeks. But does the improvement end at 12 weeks? Lastly, I wanted to present you a patient decision aid to help you and your care of acne patients to, again, allow them to be informed and allow them to be more engaged in decision-making regarding treatment for acne in particular. Let's start with the new paradigm in pathogenesis. Over the years, we've come to increasingly recognize the role of not just C. acnes, but increasingly the role of lipid quantity and, importantly, lipid quality. And increase in quantity can certainly lead to an increase in C. acnes proliferation and all of the cascades leading to inflammation and morphologic presentation of comedones and inflammatory papules thereafter. What has more recently been demonstrated is the change in lipid quality in terms of directly activating innate and inflammasome mechanisms, and then the elicitation of more inflammatory mechanisms to lead to morphological presentations, both from the perspective of saturated and monounsaturated fatty acids, as well as very specific fatty acids themselves. We've also increasingly recognized that hormonal triggers are a pivot point that affects the sebum control mechanisms at the level of the sebocyte. And these can be triggered by high glycemic foods and dairy intake, which can escalate IGF-1 and insulin levels, and increasingly recognition of poor sleep and stress via similar mechanisms, and also by other neurocutaneous mechanisms that are still undergoing elucidation. So the role of sebum in acne, at least twofold. One is increased sebum production, and we've talked about the cascade thereafter of increasing C. acnes proliferation, lipase production, leading to catalysis of triglycerides and free fatty acids, and this palmitic and oleic acid that have particular triggering factors in comitogenesis and inflammasome and innate activation. As you know, C. acnes by itself can trigger off TLR2 activation to activate immune inflammatory mechanisms via innate immunity. And then we talked about pro-inflammatory sebum, that is very specific elements, squalene, fatty acid production and desaturation, leading to inflammasome innate activation, as well as squalene monohydroperoxide peroxide and oleic acid, leading to comedogenesis. So to encapsulate, sebum, both an increase in quality and quantity can lead to acne, and the quality is pro-inflammatory. There are multiple topical options for acne that have developed over the years. Benzoyl peroxide is almost 5 decades old. Topical retinoids, the first one released in about late 1970. Antibiotics as well around that era. Azelaic acid and dapsone are more recent newcomers in relative terms. And of course, there are fixed dose combinations of the above. When we align the mechanisms of action with the topical medications themselves, we can see that they array in the following manner. There are anti-inflammatory effects and keratolytic effects, of course, of the topical retinoids, anti-inflammatory and anti-C. acnes effects of the antibiotics. And with benzoyl peroxide, keratolytic and anti-C. acnes, importantly, the latter does not elicit antibiotic resistance, which is why it's such an important component of ongoing topical therapy for acne. Azelaic acid, anti-inflammatory and keratolytic, and dapsone primarily anti-inflammatory. And you can see when you select acne monotherapies and you think about combining them, perhaps it's best to think about how these mechanisms of each of these components can fit together well. For example, if you combine topical retinoids with antibiotics, you can maximize anti-inflammatory effects through different mechanisms, but also have keratolytic and anti-C. acnes effects. If you combine antibiotics with benzoyl peroxide, you can try to maximize anti-C. acnes effect. Again, the presence of benzoyl peroxide not eliciting then the potential that antibiotics can elicit antibiotic-resistant bacteria, but you also have the added effect of the anti-inflammatory component for antibiotics and keratolytic component of benzoyl peroxide. So by appropriate mixing and matching of these treatments, you can try to elicit and address as many pathways that are important in the mechanism of action of acne as possible. Notice the one missing link is that previously there was no topical therapy that addressed SIBO suppression. Yes, we had a number of systemic therapies, including hormonal therapies, antiandrogens, such as spironolactones, some of the combined oral contraceptives, and of course, oral isotretinoin, but no topical ones. And much of that information is reviewed in multiple, extremely well done evidence-based guidelines from Europe, America, the USA. These are the JAD guidelines. Singapore in 2019 published in the JCAD, and the Canadian guidelines that were published in 2015. However, there are a number of new options that are not yet in the guidelines, and I'd like to discuss them for you here. I've selected this one because this one has a very interesting mechanism of action. This is clascoterone, 1% cream, and in its 2 phase 3 randomized controlled trials. Why 2 phase 3 randomized controlled trials? That's mandated by the FDA, 2 identically designed randomized controlled trials trying to meet the primary efficacy endpoints. And for acne, it's typically going to be lesion count reductions, as well as achievement of clear, almost clear, that surpasses the level achieved by its vehicle or its active comparator. Here, compared to its vehicle, there was a 2-to-1 level of global success on the side of the active, which is clascoterone, and important and statistically significant reductions in both non-inflammatory and inflammatory lesion counts. Why is this an important product? It's important because this product is one of the few that acts as an anti-androgen topically. Okay, in fact, let me be clear, although there have been multiple attempts by other companies over the past 3 decades to develop a topical anti-androgen, this one has now come through research and development phase 3 testing and has been approved. So although many of them came through phase 1 and phase 2, none of them until this one came through phase 3 to approval. How does it work? Well, we know that with sebocytes, the activation of sebocytes to increase sebum and cytokine production requires the binding of androgen, here dihydrotestosterone, to its androgen receptor, and then at the level of the nucleus, enhancing transcription to increase sebum production as well as cytokine production. What clascoterone does is it inhibits the binding of dihydrotestosterone to the androgen receptor to abrogate the signaling to sebum and cytokine production. And this was approved by the FDA in August of 2020. So regarding mechanism of action, clascoterone is now the only product that can claim sebosuppression to be its mechanism of action as far as a topical agent goes. Topical minocycline foam has also been recently approved, and I wanted to describe to you the value of this product. It is a foam of minocycline evaluated in moderate to severe acne. Co-primary endpoints were change in inflammatory lesions and then overall global success based on investigator assessment. Global success, 2 times greater than vehicle. Inflammatory lesion count reduction, 3% compared to vehicle. And importantly, this particular product led to the question of, that's fine at 12 weeks. It can lead to improved signaling as far as overall improvement in patients, both globally and inflammatory lesion counts, but does it lead to increased levels of antibiotic resistance? Remember, this is topical minocycline by itself. When it's released, it may well be used by practitioners like us in combination with benzoyl peroxide. But nevertheless, the question is, does topical minocycline increase C. acnes resistance? And this was evaluated in different strains of Cutibacterium acnes, where the product was found to be 4 times more active than 8 other comparator antimicrobials against C. acnes. There was a low frequency of spontaneous resistance, and the potent antibacterial activity against C. acnes was maintained over multiple serial passages. And what these passages do is they select for increasingly resistant strains, but that helps then to enrich the selectivity of bacterial resistance, but that didn't demonstrate that it was a problem as far as fomics to act as an antibacterial even against those highly selected strains. So overall, there was no selective growth advantage of this product for observed for the minocycline resistant mutants. Triferritine is one of the new advances for topical retinoids that has developed over the past 2 to 3 years. Topical retinoids have evolved in different generations. Tretinoin was generation 1. Subsequently, acetretin, generation 2. There was no topical version of that. And then generation 3 was adapalene and tazarotene. Triferritine is generation 4. Now, this is a gamma selective retinoic acid receptor subtype. We know that gamma is the most prevalent subtype in the skin of the 3 different ones, alpha, beta, and gamma. RER effects, or retinoid acid receptor effects, are due to the following: modulation of inflammation via activated protein 1, and it enhances epidermal turnover and normalizes cell growth. And this is extremely important because it helps to reduce follicular keratinization at the level of the infundibulum. That is the exit point of the sebum onto the surface of the skin. And it's that blockage that may lead to the development of comedones, and then eventually to the genesis of the inflammatory lesions themselves. Phase 3 results demonstrated global success at face and trunk. This is the first high-quality study performed with very rigorous criteria for not just facial acne, but truncal acne. So this particular trial had to evolve into a means of appropriately evaluating the trunk in terms of global assessments as well as in lesion counts. And what we found in the phase 3 results was global success both at the face and the trunk, and important reductions in lesion counts at the face, which I show here. I don't show the trunk, but it's going to be similar reductions were noted at the trunk as well. One of the uncertainties about doing a trial like this when you're using a topical retinoid on an area aside from the face, here the trunk, is also being uncertain about what the effects in terms of cutaneous intolerability are. For example, we know that while there are high density of sebaceous glands in the face, the density is a little bit lower, and these sebaceous glands are deeper on the torso, the back and shoulders. So the question then was going to be, is it going to be more irritating on the torso than on the face? And here I wanted to show you the different panels, which are the facial tolerability scores and then the truncal tolerability scores. With the facial tolerability scores, the hatch line represents the designation of mild levels of these different signals: erythema, scaling, dryness, stinging, burning. Now, at week 1, this is a very typical retinoid curve of intolerability. We see escalation in all of those parameters: erythema, scaling, dryness, stinging, burning, at week 1. And that peaks and then it progressively declines thereafter. So whether it's tazarotene, adapalene, tretinoin, this is characteristic for all the topical retinoids. In this particular case, on the face with trifarotene, we saw that the signals approached mild, but never touched it in terms of mean averages. So it was going to be progressively heading towards the dash line of mild intolerability. When we compare it to the trunk, we see that there is not as a steep elevation within the first week. In fact, there's a gentle upslope, a little less gentle for erythema, a little gentle upslope, primarily peaking at the top of the hill at week 2 to 4, and then progressively declining thereafter. And all of these levels were less than halfway to mild. So it looks like overall the product was better tolerated on the trunk than on the face. And even at the level of the face, it was well tolerated because the signals were all mean levels below mild. So this product was approved in October of 2019. And it was approved, and it's the only topical product that has been evaluated to this level of scrutiny for both facial acne and truncal acne. And in fact, even in the systemic studies, we don't see this level of scrutiny in terms of global assessment and lesion counts for any of our systemic medications. I wanted to now talk about sarecycline. This is a 3rd generation narrow spectrum tetracycline class antibiotic. 1st generation, 2nd generation, you know well, these are tetracycline, doxycycline, and minocycline. What is different about sarecycline? Well, it's much more focused in terms of targeting C. acnes, and it has very little activity against gram-negatives. And importantly, the structure at C7 was modified. You see this much larger moiety at C7. Why was that developed? Primarily to overcome tetracycline resistance mechanisms by bacteria. So that's been generated to make it more resistant to antibiotic mechanisms for antibiotic tetracycline resistance. Let's take a look at its phase 3 studies, just over 2,000 patients in moderate and severe facial acne. Over a course of 12 weeks versus vehicle, global success was 20% compared to 13% for placebo, and the difference in inflammatory lesion counts was important and significant at 15%. So this was approved in 2018. So it provides to you a more narrow spectral focused C. acnes targeted systemic antibiotic, and it has a built-in moiety to try to reduce resistance. Let's talk about new uses for old treatments or good old friends that we use on a regular basis for other things. So for example, topical ketoconazole. I found this to be a really useful finding in terms of the value it had in improving acne. In this case, it was in adult females. There were just over 40 patients in a double-blind randomized controlled trial against placebo creams. And what they achieved over a course of 8 weeks plus 2 weeks thereafter of observation was a global success rate, achieving clear, almost clear, 3 times higher than the placebo cream. And I think this is a really important, useful finding because this is a cream. It's not a gel, so it's not particularly drying. It's not particularly irritating because many of us have used topical ketoconazole and its cousins, clotrimazole, and probably Loprox, Lotrim, in other conditions, specifically in yeast-induced and fungal dermatitis. So what this demonstrates is high levels of efficacy, likely related to its anti-inflammatory, anti-androgenic actions, as well as reducing the activity of lipase from Cutibacterium acnes. So this is a useful product to have in your toolkit, particularly in the situation of patients who are irritated by their current topicals, or if they need something to be used under their mask through the course of a day. And this is fairly gentle, and it's more moisturizing, less irritating than some of our gels with topical retinoids, benzoyl peroxide, some of the alcohol gels or lotions that contain topical antibiotics. I also wanted to demonstrate to you this particular study, which was really interesting in terms of trying to understand what was going on. This was a 24-week split-face investigator blinded vehicle control study, so a high-level study, randomized controlled trial, split-face, patients had moderate to severe facial acne. Look at the duration of treatment. 24 weeks is twice as long as any other study I've just mentioned, which is 12 weeks. Why 12 weeks? That's just a legacy historic duration that was used for approval for clinical trials in acne. But this trial extended it twice as long. So what can we see from that? Well, at 12 weeks, you can see that the yellow bar, which is the active product, outperforms its vehicle by almost 3 to 1. Okay, 31% patients achieving clear, almost clear. But the most important point of this is that if you double the duration of treatment to 24 weeks, you actually double the proportion achieving clear, almost clear. We didn't know that. We'd never seen that before. In fact, this study demonstrates that cutting your treatment trial duration off at 12 weeks is where you are at the midpoint of this progressive improvement in achieving global success. And if our trials were out to 16, 20, or 24 weeks, we'd get a much clearer sense of its overall level of efficacy. And you can see it's starting to plateau at week 20 to 24. So what does this mean? Well, by week 12, about 1/3 of your patients, if they are similar to those recruited in the trials, will be heading towards clear, almost clear. But 2/3, twice as many, will be getting there if you extend your duration of treatment longer. Okay, so I think that's a really important practical point in terms of how we treat patients in clinic and an important clinical point in terms of how we do our clinical trials. They may be too short to show maximal efficacy. Now, one of the important things about that trial is that over time, as there is less overall global success in acne on the vehicle side, we should see increasing number of scars, and we do. On the other hand, with the active side of adapalene and BPO fixed dose combination, we see progressive increase in efficacy in achieving clear, almost clear, which means that the number of scars compared to baseline should be leveling off so that it doesn't change much. It should basically follow along the hatch line or just rise above it a little bit. But in fact, the reality is we see this yellow line, which is dipping in a negative slope below this threshold line. What does that mean? I think that means that not only is this product mitigating increasing scar formation, it may be actually reducing the number of scars over time, which requires more studies to be done and more confirmation. We already know that in other studies using, for example, adapalene 0.3%, that there is an increase in collagen formation that may well be part of the reason for this entire observation. So let's start putting it all together. One of the things I wanted to do was to try to engage patients more in decision sharing about acne treatments, about any treatment, talking to the patients, trying to understand what's important to them, and then balancing our expertise, which is evidence and your own experience, with what's important to the patient, their values, and of course, what they wish to see happen with their condition. So what we developed was a patient decision aid, and patient decision aids are tools to help patients and doctors engage to help make better healthcare decisions together. So this is the acne patient decision aid. It is available for use complimentary. There are no charges for use and there are no royalties. This was developed to be open access and freely available. And it's available on this website, Informed-Decisions, and it's there to help you and your patients hopefully engage more and to discuss about what's important to them. So with that, I'm going to stop, and I wanted to just update you on what I've done, which is to provide you a little bit of information on what's new in acne, new paradigm in pathophysiology, some of the new treatments that I've tried to curate for you, some of the interesting aspects that I think you might find of value when they are released in your jurisdiction. There are new ways of using old treatments. There are new ways of looking at what we've been doing as far as clinical trials, and new ways of using treatments that go beyond just treating acne. And I've talked about how it might be able to help acne scarring. And finally, a tool to help you with shared decision-making for you and your acne patients. Thanks so much.